Hello, welcome to another episode of the Project Purple podcast. I'm Dino Verley, founder and CEO of Project Purple, and we have a very exciting interview coming up with a special guest after a few quick updates. Since 2010, we've contributed over $3 million and counting to pancreatic cancer research efforts. We also have allocated over $1 million worth of aid to more than 1,300 patients and families through our patient aid programs. Your monthly or one-time gift can improve patients' lives through research and assistance programs. You can donate now at projectpurple.org. Pancreatic cancer does not rest, and neither will we. Your support is truly appreciated. If you're looking to get involved in one of our events, whether that means joining a run team, participating in a virtual run walk, group fitness, golf, or anything else you can think of, visit projectpurple.org/events to learn more. Without further ado, let's meet our special guest. Coming to us all the way. This is, I like say all the way. This is kind of far, like coming to us across the pond, Dr. Emily Britton, who is a doctor of medicine at Bristol Medical School. She's at the University of Bristol. She's ending her surgical training. She's focusing in pancreatic disease, and in particular pancreatic cancer. So coming to us all the way from the UK. I believe she's in Bristol. So welcome to the Project Purple podcast.
Thank you so much for having me. It's an absolute delight.
So as I know we were playing catch up before we hit record here. We have guests from all over the world. I love interviewing. We didn't say this. I did tell you this. I was just over in London for the London Marathon, spent a couple of days. I think, and I know you spent some time here in the US, which we might get into when you introduce yourself. I've fallen in love with London. Like the last 3 years, I've gone for our marathon and for the London Marathon, and we're one of the charity partners. We're super excited. Running marathons is a big part of what we do here. It's always been part of it. And the last 4 years, we have been blessed to be an official marathon charity partner with the London Marathon. 2025 will be our biggest year with them. We'll have 30 runners for 2025, and so we're super excited. But I was in London 20 years ago, spent some time in Scotland when I was in the financial services business. We brought some guys to do this golf boondoggle, and then came down to London and spent a week. And, you know, when you're like in your early 20s, you're just like, whatever. Like, I don't think you really appreciate everything of what a city has. Like, you're just kind of maybe self-centered a little bit. And I know when I was in that age, that time of my life, I was very self-centered. But going back the last couple of years, London is just so cool. I think it's like one of the coolest cities in the world. And we're not far from New York City. But I said this 20 years ago, and I stand by it again today. I think London is more diverse than any city that I've ever been to. And I've traveled pretty extensively here in the United States, and I've been to Europe quite a bit over the last couple of years, to Italy and to the UK. But, you know, from a cultural standpoint, from a food standpoint, from an entertainment standpoint, I mean, London's gotten really big and really wide, which is different than some of the cities here in the States. Like, you know, Chicago's compact, New York is super compact. Even though like New York now is spreading to Brooklyn, which I know we talked a little bit about, you know, when you come here, you know, now Brooklyn's considered part of New York City, but like, you know, 5 years ago, that wasn't really the case. No one really ventured to Brooklyn, but now you know, I think COVID made it hip and chic. But London is just so cool, just such a great city. And, you know, we've been blessed on this podcast to have so many people from the UK on the podcast, survivors and clinicians, and talking about, you know, pancreatic cancer. So I just love bringing people over from the UK. So thank you for taking the time. I know that the time difference, you know, is sometimes an issue. It's early for us, but midday for you guys. So I'm really excited to have you on. And full disclosure, another corny term that I say often, you did email us about the research that you're doing. And when I saw it, I was like, oh man, you know, this is a great opportunity for the podcast to share with the audience and with the people here that listen and watch the podcast with all the great things you're doing. So with that, I'm going to stop talking. We're going to hand it off to you, Emily, to talk about all the great things that you're doing and a little bit about your background. And with that, the microphone is yours.
Okay, well, thank you very much, Dino. I'm glad that you love London because I love London too. I moved to London when in 2002 after finishing my history degree, actually, which was my first degree. I then spent 5 years working in the UK government in the Ministry of Justice in the centre of London in Westminster and Whitehall, doing strategy and policy advice. Before deciding that I wanted to be a surgeon. And my initial desire was to go to medical school and become a surgeon to treat breast cancer, as my family have been very closely affected by that. And then I got to medical school at St George's in London and discovered that there's a whole range of other really interesting organs and diseases that I didn't know about, and I became increasingly drawn to things related to the pancreas and liver. And so when I pursued my surgical training, that is the area that I have chosen to specialise in, and I have moved out to Bristol to finish my higher surgical training and to hopefully become a specialist in pancreatic cancer surgery.
So I got to jump in here. I got a
Yeah.
question. So, because I'm always fascinated, like I know why I'm in this space. What was it about like GI? I now use the term GI cancer, pancreas cancer, like that, like really like, did you sit in like on a Whipple or was there like a mentor that just like, drove your fancy to say like, all right, like I'm going to go into this space?
I think that the combination of the medical complexity of the organ, the organ in health and the organ in disease for pancreas is very complicated. It's involved in it's so key to digestion, nutrition, to glucose and blood sugar control and management. It's difficult to find. It's hidden right at the back there, so it's surgically difficult to access, and it's really at the heart or the soul of the abdomen at the back. So it feels very crucial and very critical. And when you expose it during the operation, you see the whole of the clockwork there, and it's the sort of just the significance of that, I think, was attractive to me. I think there was a technical challenge in the procedures and in the complexity of the procedures. There's an intellectual challenge in understanding and managing the medical consequences of having disease in the pancreas. And yeah, it just sort of had me hooked.
I love it. I love it. I mean, I think you mentioned some amazing terms there, like complexity and the technical aspect of it. And I think that's something that, like, for people who are not familiar with pancreatic cancer, I think that's like one of the things that really make it unique, which it is. It's very unique. And I think as we have gone down this road now 15 years, that's like the biggest challenge, right? Like, why haven't people often ask me, like, why haven't we made the strides that maybe other cancers have? And when you talk to clinicians, like the complexity of it, the technical, the technical aspects of like surgery, where anatomy, the things that the pancreas does. I'm not a clinician. I've taken very, very limited medical classes in my training, but I would have to go out on a limb and say like the pancreas might be the most complex organ in the body, potentially.
I mean, certainly in my view, but I may be biased.
Yeah, well, so am I. But I think, from what I've seen and from what I've heard from clinicians like yourself, like this disease is just super complex. And that's like one of and that's just like hearing you say that, as someone who's in it day in, day out, you're on the front lines. The complexity of this is just so hard to understand, I think, maybe for the average person that, again, isn't, and I'm not trying to like be disrespectful to anyone, but just if you're not in the space, you just don't understand like how complex this is. So I guess my point here in saying is like you validate like what we know as advocates because we're in the space, but also what patients and their families need to understand. Like this is a super complex organ, and there's just really technical aspects and complexity in terms of all the systems that go in to
Yeah.
treating this disease.
And it's sort of unlike cancer in other areas because it's so hard to access. It it can be very difficult to say if a patient definitely has cancer or definitely doesn't. And the treatments are all, they're pretty significant surgery to have to treat it. And it's a lot to get your head around as a patient. The idea that you don't know if you have cancer or not, but you're being offered a huge operation with lots of potential complications and consequences. But if you do have cancer and we don't do that, then that can be, a pretty that can be fatal if we've missed the opportunity there. But at the same time, we can't tell you if you definitely do or not, and we might do this huge operation for you for what was benign, something non-cancerous. And I think the nuance in that conversation and decision making and being able to support and counsel patients through that is one of the real privileges of being a clinician in this area. And certainly the clinicians that I look up to are the ones that I think do that just so beautifully.
It's awesome. I love it. I love hearing it. Again, we were catching up beforehand. This is having young people in this space inspires us so much because, as I said before, like you guys are the future of this space. And so, I mean, for those watching or listening, I mean, how do we, again, I get this question a lot, like, how do we create change? And it's like, we've got to inspire people like yourself to get in this space that are super talented, super young, have a lot of energy to do the things you're doing. So it's just awesome to hear. And I always get excited when we have clinicians on because not to sound like a broken record, you guys are on the front lines. You guys are actually that infantry in this war against pancreatic cancer. So it's just so inspiring for us and just be able to share this with the audience about all the great work you're doing and the reasons why you're in it. I think is really inspiring for me, at least from a patient advocacy standpoint.
That's also kind of where I think probably because I've come from a sort of arts background with history and working in government, I'm kind of not that lab-based scientist clinician. I come at this from a very interpersonal, personal choice. I'm really interested in individualized care and what patients think and what the right option is for that individual, rather than treating the person rather than the appearance on the imaging is really important, I think, for me.
Yeah.
And so a lot of and this research is around trying to build a consensus across hearing the views of patients, hearing the views of carers, hearing the views of scientists, hearing the views of surgeons, oncologists, all of the different people that are involved and care about patients with pancreatic cancer, and understanding how we best evaluate the surgical treatment that we offer.
So I want to ask a question, and I'm going to make a statement. So being in the UK, so you spent time in the US and being in the government position, maybe you've seen this, working in the government. The UK does have a public healthcare system, which we were talking about earlier. And sometimes when you have kind of like the standard of care, right? I guess I would say people get put in this box of standard of care, and something that you just said, the individual is really the individual care, like a personalized approach to each individual. And I just recently had a clinician on, and I was talking to another gentleman who's eventually going to be on the podcast as well, in the clinic, like another clinician. And, this idea here in the States, at least, has come to where, we've got to look at every case individually. And there is this, I think like 5 years ago, the New York Times did this big piece right before COVID, or a year before COVID, about, personalized cancer care. I think Memorial Sloan Kettering. And this is kind of, I think, when the boom of genetics started here, where, they realized oh, certain people have these genes, and these genes factor into treatment and how certain drugs work, and this whole personalized medicine. And I don't think we really saw the advances like in pancreatic cancer that we saw maybe in other cancers at the time. But now we're starting to see that, I think here in the States. And so I was talking to these two clinicians, but they both, and one of them is a longtime researcher, is a huge lab here in the States at one of the major cancer centers. And he said, this disease is just really complex, and we've really got to kind of bring this back to basics and really look, to your point, at everyone individually, because everyone is so different. And I think as a patient advocate, what I hear from patients, like I was just talking to someone last night, I mean, he's stage 4, he's been 2 years in his fight. Everyone's told him he's had 6 months. He feels great. He's running, he's lifting weights, like he's got really super high quality of life. And he said to me, it's just really frustrating because I can't find other people like me right now. And I said to him, I said, well, but that doesn't mean anything is wrong. We just have to understand that this disease is so different. And I think that's part of the challenge when maybe with like a standardized care or public health system, everyone gets the same type of treatment, which is good and bad, right? Like, because as we were saying before.
We sort of talked about this a little bit
Yeah.
before. There's huge advantages is that the minimum standard of care is really high in our health system. It's proven, it's safe, it's effective, and it is and it should be available to you, whatever your income, wherever your race, gender, ethnicity, and wherever you live in the UK, which is wonderful because there's so much health inequality. But the sort of downside of that is, in order for us to be certain that that these safety and standard things are met, we can be slow to bring in innovation. And we can sometimes look with envious eyes to radical treatments and trials running outside of our very tightly controlled healthcare system and framework, and the exciting opportunities that they might be able to offer. But the thing with pancreatic cancer is, because it is still such a relatively small number of people who are affected, it is hard to we don't have a huge number of people who are stage 4 anywhere in the world to put these patients in touch with one another. And I think that must be difficult and lonely. I actually I did interview a patient with stage 4 cancer who had recurred after having had curative surgery, and he's had 48 rounds of FOLFIRINOX chemotherapy, and 3.5 years later is still working. But for him, he doesn't know anyone in his situation, and so and he's so far, I suppose, outside the normal of what is expected. Should he have other rounds of treatment, or should there be other options for him? And no one really knows the answer to those questions, I think.
Yeah. So your study, though, is, if we dive into the project, like you're proposing that, like, we do study this stuff, and like we try to see like what is actually the outcome.
My study is about trying to standardize how we report on outcomes. So a lot of people are doing a lot of research around the world, but if we don't report the same things in the same way, we can't pool the data from these different trials. And if we don't analyze the right outcomes, then we might not, the results might not be relevant. We might not be answering the questions that are important. And so my study is looking at everything that is being reported at the moment, and then working with and then I also interviewed then a range of patients and healthcare professionals. The patients were all from the UK because of ethical considerations, but the clinicians came from across the world to ask if there were anything missing. And then we are just in the process of an international online voting survey where everyone, patient, carer, healthcare professional can vote on the outcomes from that list that's been generated onto what is most important. And the idea is to try and narrow down to a core set of sort of 8 to 10 outcomes that should be reported in every research project or audit or registry, so that we know that on the 8 to 10 things that most matter, everyone is reporting it. So every data from that trial will be able to be pooled into the things that are most relevant and most significant. Because sometimes we get really bogged down in the details. We as healthcare professionals have lots of, we're interested in lots of very technical aspects of the surgery and surgical techniques. Hospital management and administration are really interested in things that drive costs, like length of stay or economic analysis, or safety audits might be more interested in infection things and looking at lots of different infection measures. So we can sometimes report so many outcomes in a research that it's hard to see which ones are the most important. So there is an organisation called the COMET Initiative, which has developed this method and process of people in their relevant field trying to develop this core. It's called a core outcome set, which then should be applied. So if you were an editor in a journal and you were looking to publish and you were reviewing a paper or research, you would want to know, has this research reported the core outcomes for your disease or for your intervention? And so it's to try and encourage and standardize the research that's done, and that hopefully reduces the research waste. It hopefully makes our research more relevant because we know that it's answering the outcomes that are important to patients and healthcare professionals, and that we're not letting those important outcomes get lost in the sort of trees of all of the other things that we could tell you about or that we do measure for other reasons.
So so many questions just came to my mind. So the first one, where did you come up with this idea?
So like I say, the COMET initiative has been going for about 10 or 15 years, I think now.
Mm-hmm.
And that came out of the World Health Organization started trying to standardize outcomes in cancer in the 70s. And then there were other groups, primarily actually from rheumatology and orthopedics, that were looking to standardize how they reported things. And they developed some methodology. And then this group, which is sort of a European group, there's UK and European researchers, but it's now an internationally recognized group. And they developed this methodology that said, if you want to develop core outcome sets are good. They help us make research more relevant and reduce research waste. And this is how you develop a core outcome set. Bristol University has developed core outcome sets in colorectal surgery, in breast cancer surgery, in esophageal gastric surgery, in elements of vascular surgery. So it was quite a well-known thing at the university, but no one had looked at pancreatic cancer. And at the same time, like we were talking about before, there hasn't been that sort of real transformation in outcomes that other areas have seen. And there's also been a huge growth in the number of surgical techniques, things like robotic, first it was laparoscopic surgery, now there's robotic surgery.
Yeah.
There's all sorts of different combined chemotherapy, radiation, invasive techniques. There are different chemotherapy regimes. There's different ways of organizing your chemotherapy or surgery. And it's such a small number of patients relative that to try and get trials with enough patients in to really say, what is the optimum thing? What is that? More quickly, we need to all be reporting the same things.
Yeah, it seems like common sense. I'm trying to pick my words
I know,
carefully,
right?
carefully, Emily here. Like, like the definition of insanity is doing the same thing over and over again and expecting different results, right? Like, I think I said that before in the opening, when we were catching up. But like, so like to me, like as a patient advocate, like I know, like, because I've been in this space long enough, this is like what it's like common sense, right? Like patients who go to meet clinicians should have like, okay, here's the roadmap, right? Like here is statistically, and again, science is trial and error, but it's also based on like the data, right? Like the data doesn't lie, right? So, but if you
Um,
have that data to show like okay like if you do like to your point if you do like and I'm just gonna like probably this is gonna be really crude but like if you do a robotic versus like doing a Whipple but if you have this data set like a traditional Whipple this is what you expect but I feel like so then let me ask you this question like since this project has started like collaboration to me, I guess my point in here I was going to say is like that's like a no-brainer to me, but I know there's a lot of ego in the space and there's a lot of like barriers like when I say I think some of it's ego by clinicians, which whatever. Like you have your Nobel Prize and now you think like you're better than everyone else or whatever. But also I think though there's maybe more institutional like barriers like institutions not everyone wants to play nice in the sandbox and I don't think it's necessarily from the clinicians, but I think there's like barriers because we've seen it. We've done some really big projects. Like our early detection study, one of our early detection studies, ranges 25 centers. And in the very beginning, there was a lot of institutional BS, not necessarily from the clinicians, but from the institutions themselves that weren't willing to like share data, which to me is like that's part of the problem, right? Like that's a barrier in the space. So I guess my question here in this, because this is a collaborative effort, right? We need everyone to get on
Absolutely.
board.
Yeah.
How do we then like get around those challenges of ego and like institution?
I mean, I think I hope that that is a an attitude and a set of values that are slowly being pushed out of the surgical and medical space.
Yeah,
Because I think the world is a smaller place, and we all know that it works better if we share and get on.
correct.
And when we're facing something with such a serious prognosis as pancreatic cancer, we should, it's our responsibility to do everything that we can to get to the strongest evidence base as quickly as possible. And that does mean sharing data, sharing methodology, but it also means talking the same language, talking about the same outcomes, measuring things in the same way, and agreeing on what is important. But and it's not necessarily from an ego or institutional point of view, but people will be doing research projects with sometimes it's looking very specifically at one particular thing, is laparoscopic surgery more cost effective than open surgery? And that's that's a very specific thing that it's looking at. So people can actually run a project and answer that specific question that they're trying to answer, but they might also be missing the opportunity to provide data to a larger data set because
Mhm.
they'll have patients that are relevant that could be pulled into it. So it is, I suppose my project is just about trying to add something into the collaboration, data standardization, trying to provide a framework that helps people do that. Doesn't tell people what to do, but is developed by the people who are doing this work, doing the research, the patients who are having treatments, the carers that look after them, and the surgeons delivering it, and trying to say, tell us what is important, and then we will
Yeah.
give you this, we will give you this framework that says this is how you can measure it really reliably and consistently.
It's powerful stuff. Uh, I love it. I mean, as a patient advocate, the more research, the more data, the more, as to your point, the framework that we can put around this space and this disease. Knowledge is power. So the more that we can provide to clinicians and to patients as they go through those journeys to have better outcomes, we're all for it, right? Like everyone's for that, right? And so this is just so powerful.
And I also think that what we've seen in the last couple of decades is an increasingly engaged, intelligent, and knowledgeable patient base.
Yeah,
And that sort of the days of patients coming in and just want to be, and just wanting to be told, what they're going to have and what that is kind of over. Um, and
just a
so
little. Yeah,
at the same time, pancreatic cancer surgery had, 40 years ago, it had some pretty high mortality rates and
correct.
it was pretty dangerous stuff. And there's still there's still a sense of that in the profession, and there can be a lot of anxiety and concern about, understandable and
Yeah.
rightfully about bringing in new techniques or doing surgery which is too aggressive and too dangerous. Um, but at the same time, in emergency surgery context or in trauma, when we can be much more aggressive with much less anxiety about it. And if someone has pancreatic cancer, then they may want us to be more aggressive. They may want us to take more risks, or they may say, actually, no, this surgery that you're offering me, where you take out all of the pancreas, bits of my aorta, bits of my, venous system, and leave me, insulin dependent and on all loads of things, isn't worth the consequences of that to me. And I think one of the interesting things in my project is trying to elicit and really understand people's perspectives, and making sure that we have those priorities balanced. Because if we're all obsessed about this sort of surgical worries and we're not listening to the patients, we might be missing an opportunity. And at the same time, we might be busy developing surgical techniques that patients would say, actually, no.
Yeah. It's fascinating and so powerful, but like again, it boggles my mind that we haven't gotten there yet. And that's like the thing, like you come back to this, like, again, as a patient advocate, like having this information readily available already. But this is what inspires us to continue to do these things and to highlight these projects because they are critical. And this is a great time in this space. There's so many good things happening. And so for those patients and their families watching and listening, like this is the hope and the inspiration that, a project like this can lead to, higher survivability and better outcomes, for patients to have that knowledge, to make a very informed decision.
I mean, I was just trying to help people all talk the same language, and trying to help make sure that every bit of research done in the field has the biggest impact.
It's powerful. I got a couple questions here
Yeah,
left,
yeah, of course.
and then we're going to share where our audience can connect with you to learn more, whether they're in the UK or here or wherever they are in the world. Do you think, now just thinking from this, and I know we talked a little bit about this before we hit record, like AI. So where does, I mean, that's kind of a big buzzword right now, right? Like through every industry, right? Like AI, just over, I don't know if that's like I don't know if like the powers to be are trying to distract us from something or like trying to tell us something. I think, there's always like pluses and minuses to everything, but do you think AI factors into this at all?
So I think AI is going to be increasingly a part of an essential part of medical care. I think there's its biggest use so far that I've seen is in really understanding imaging. So,
Mhm.
an AI model can take thousands of CT scans, and it can see things that a radiologist or human couldn't see, and it can detect patterns, and it can detect lesions that would have been missed otherwise, or it can diagnose, the likelihood of malignancy in a lesion that might otherwise have been considered benign, for reasons that we don't understand because we're not AI and we don't have the algorithm. But just by looking at those things, it picks up patterns that we wouldn't recognize because of the volume of data that it can look at.
Yeah.
So I think that's, as we do more and more imaging, for incidentally and for routine investigations, there's a real chance to identify things like pancreatic cancer earlier. Particularly in that bunch of people who are over 50 who have a new diagnosis of diabetes. We know that there's an increased number of those people that will go on to be diagnosed with pancreatic cancer in the next 3 years. So there's stuff there. I think that there's also going to be things with AI and risk prediction, and really being able to give patients very personalized information about the sort of risks and complications and mortality that they might experience with having surgery or surgical procedures. I hope that it will also help us identify and stratify patients who are having potential complications after surgery, like pancreatic leaks and fistulas, which we, are very concerned about. And that might help us develop really slick algorithms for how to manage those patients. I have techno joy, I think I would describe it. And I'm very excited for the, for some of those advances. I think that there'll probably be also lots of clever stuff that AI can do in terms of understanding personal epigenetics of tumors and individual tumor biology, which I think is really important in pancreatic cancer. But that goes into a field of lab-based medicine that is outside of my comfort zone.
Yeah, no, it's a great, I mean, so one of the things I think that leads us into, though, that we talked about earlier is, I think, and I guess you would agree to this, like as we move forward, and I know in the public healthcare system, it's a little bit different with standard of care. And even here in the States, like, everyone, depending on where you go, you might get just standard of care. But so we do foresee like this project and other projects, like really going down the space in pancreatic cancer space of like individualized care for each patient being really different because of the complexity of the disease. So would you agree with that? Like maybe like if we had a crystal ball here and we could say like in the next 5 to 10 years, like where does this space go given what you're seeing in the clinic and like what we see, from patients who, are all on these different types of trials or combinations of the drugs that they have. Do you think in 5 to 10 years, like we'll see just like individualized like care specifically for pancreatic cancer? I'm not talking about any other cancers here, but
yeah. I know that there are definitely researchers in the UK who are working in tissue and biobanks and internationally as well. And I think the more tissue that we can collect from pancreatic cancer, the quicker that we will make those sorts of that sort of progress. But I think that there are patients who have a biology to their tumor, which means that certain drug therapies will be more or less effective. And depending on that, they may benefit from having systemic therapy before their surgery, or potentially not. Potentially, they would be better to have surgery and then have systemic therapy. So I think that will become important. I also think that there will be more personalized treatment of things which are at the moment, certainly in the UK, not considered sort of contraindication to surgery. Things like having an isolated liver metastases at the time of diagnosis, or having a recurrence of the pancreatic cancer. There are places where people are getting positive positive results and a survival benefit from doing further surgery in those patients, or offering surgery where it wouldn't have been offered traditionally. So I think but again, I think it's so individual, the patients that will benefit from that. And it depends on, on their health and fitness, but also what their tumor, the biology of their tumor is. And I think we will get much, much more information about that, and we will get much better at really delivering really delivering personalized care plans for patients. Possibly not in the next 10 years, maybe 20.
Yeah. Well, I know, we talked about it earlier, before we record, you look at the numbers, right? Like, so we need the numbers. And I think that's just a testament to why these big studies are critical, right? Because like we have to get the data. Science is trial and error. So unless we, learn from the things we are doing now and how we can improve that, or what are the commonalities, what are those common links? But you need the data to prove that, right? Like we just can't hypothetically say here, like, I know these are tough questions. I have a lot, I call them loaded questions, right? These are loaded questions. But the way to get, the answers is to get the data. And that's where we need this collaboration, not just here in the US, but across the board, across the world. Like to your point, having, input from Italy, from Greece, from the UK, from Israel, from here in the States, from other places in the world as well that deal with this disease, Asia. We've got to do that. So I'm excited because, as I said, you're on the front lines. It's exciting to know that these things are happening for our patients, not only just here in the US, but worldwide. And sometimes what happens in Europe, in the UK potentially could, benefits what happens here in the States, because I know the rules are a little bit different, and vice versa. What happens here in the States, benefits people worldwide as well. So it's just exciting. It's super exciting for me. I get jazzed up about it because, again, it's the inspiration as a patient advocate that we need. I've got a statement, and then I got a question, my last question.
Okay.
Well, the statement is kind of a question. So oftentimes when we just met for the first time, we caught up for like 20 minutes, and then, we get right into recording this. And then as a guest, and as I'm listening here, have you ever looked, I know you said like you worked in government for a couple years and like in strategy. Do you ever look at like that past experience? And then you said, well, then I shifted into medical, which is like a total 180 degrees, right? Like it's a total, like that's a total shift. Like you went from policy to like, clinician and research and everything. But do you ever look at that time? Like you kind of look at like, working in government, you're working with multiple agencies, different personalities, different people. Like there's a lot of layers, there's a lot of systems in there. And now you shift to medicine, and it's somewhat similar in the aspects, but now like you look at this project, like this project is like huge in the sense that, collaborative effort. My question here is, like, have you looked at that past experience? And I know you kind of like, you're like, well, this is what I did before, but now I'm in medicine, kind of like poo-pooed it a little bit. But I often, as the guest, like you see this arc that people are on, like they start at this one point, or they have these certain things in life happen to them, but then now they're in this place. And if they didn't have those experiences, maybe it didn't prepare them for where they are today. Does that make sense?
Yeah, I think that absolutely I've ended up doing this project because of my background in government. I think it's, I'm essentially trying to develop a policy for reporting in pancreatic cancer surgery studies. It's a very similar sort of set of, trying to work collaboratively, trying to understand people's interests, trying to bring in as many views, trying to engage with as many people as possible. It's a huge public engagement project, and stakeholder. See, that's a word I learned in government. Stakeholder.
Stakeholder.
And I think but I mean, I went into government because I was interested in helping people and trying to improve public services and public and care and provision for the public. And now I've just kind of refined the avenue in which I am trying to do that. But yeah.
Well, I'm glad that you decided to make the change and you're in the PC space instead of the government space. I'll just put it out there because again, it's inspiring. I mean, I get so excited. this is the future. You're the future of this space with many other people. So, as I said in the very beginning, I think we were off camera. You know, I look at things very common sense wise and business sense. And when I got in this space, no disrespect to anyone, but I remember going to like an AACR meeting or something like the first couple, or no, it was like ASCO. And I'm like, all these people are really old, which is good in a way, but like, where are the young people? Like, where are the young clinicians and scientists? And then, recently went to like an AACR meeting in Boston, which they do this big pancreatic cancer meeting. And there was like a ton of young people, and I was like so excited. And that's the future. Like, we need to inspire and encourage young clinicians like yourself, who come from different backgrounds. I think that's important as well, right? Like, you bring a different type of mindset, different skill set to the table, to not only deal with patients in a much different way, but also look at the problem and try to find solutions outside the box. Sometimes we need to do that because, again, the definition of an insanity is doing that same thing over and over again and expecting different results. So, truly inspired here, Emily. My last question for you, and then we're going to share with our audience where they can learn more about the project and more about the work you're doing. And this is a loaded question. There's no right or wrong. I always ask this question at the very end. It's just very curious to me. Given your experience, what you've gone through in your career, how do you define the term pancreatic cancer? What's your definition?
Oh, so my project looks very specifically at pancreatic adenocarcinoma, because that is over 95% of the malignant lesions in the pancreas. And the outcomes are very different with the neuroendocrine tumors. And the risk benefit analysis for precancerous lesions like IPMN is different. So my project is sort of very tightly controlled around pancreatic ductal adenocarcinoma or adenocarcinoma. But I suppose as a clinician, I'm probably slightly broader if I were talking to a patient about it. I think certainly neuroendocrine tumors are different, and we shouldn't. It's confusing to patients,
Right,
and lead to a lot of anxiety unnecessarily. If you tell them, a neuroendocrine tumor patient, that they have pancreatic cancer, that would, I think, be unhelpful. But these precancerous lesions and things like that, we don't know often until, and often in pancreatic cancer, not often, but it's not uncommon to know that there is something there and that we're concerned about it, and then we won't know exactly what it is until it comes out.
powerful.
That's one of the challenges, isn't it?
Yeah, I mean, but I think they're again, to go back, like, we've got to do this data, like, all this, like, that's what's going to prove this thing. And I know we talked about this a little bit offline before, is like, again, I don't think we've done enough research in some aspects to get to where we are having a success, right? Like, 99% of the research is going to fail, but we've got to have those failures before we can have those successes. And I think we have seen some success in some spaces, like, clearly, like you mentioned, IPMNs. I know there's a lot of work, like we're funding some new work in IPMNs. I think we understand those better than we did 10 years ago. Genetics is another place. I think now, like, they're here, at least here in the States. I know it's a little bit different in the UK. Genetics has become a big push. I think some of that's been that personalized medicine, where we understand, like, there are certain genes, and we do need to be cognizant of the genes, and we've done a lot of research, or funded a lot of research in that space. But then there's 80% of sporadic risk, like sporadic cases, right? 80% of the cases, potentially here in the United States, just come from like the sporadic occurrence, right?
Yeah.
Like, why does that happen? So that's a big number, and we've got to understand that more, but we've got to put the research into that, right? And that's, I think, the biggest stressor here is, we've got to do the work. Like my dad used to say, you got to do the work in order to get the results, right? And so if we don't,
I was just going to say, like, the way I sort of look at it is, we need to we need to improve our ability to detect pancreatic cancer, right? We've got to get it diagnosed and get it diagnosed early, because we know the earlier we get it, the better treatment options and prognosis is going to be. We've got to look at how can we get more patients through curative treatment. So how can we change the surgery that we're doing, or the systemic therapy, or the combination of the two? How can we reduce and make the surgery safer? How can we do extended surgeries to take bigger tumors out? Sort of how can we improve the number of patients that we can get through curative treatment, as well as increasing the number of patients that we diagnose early anyway. And then I think we have to look about how we surveil and follow up the patients that we have got through. And, how do we then treat recurrence in an effective way? That's kind of, and I think we need to go all out on all of them.
Yeah, it's a daunting task, but I think the space is up to it. But again, this goes back to, you got to have the data to prove the results, right? And these research projects are critical. So, Dr. Britton, thank you for all you're doing in the space. For someone listening or watching, if they want to get involved, if maybe there's a center, someone who works at a center and they want to get involved in the study, or if someone wants to learn more about the work you're doing, where's the best place for people to connect with you? Is that like the web? I know I think there's a social media as well, the website.
I would absolutely love to hear from anyone and everyone. The more opinions, views, and ideas, the better, as far as I'm concerned. You can tweet at the study, or X, I don't know what we call that now.
Yeah. But, I believe it's X, yeah.
Yeah, this study's X handle is at PANCOS 2024. Or you can engage with me on social media personally at Emily J. Britton, or you can drop the study an email at emily.britton@bristol.ac.uk.
Awesome.
I will have a website coming live, and that will go onto the onto X and the social media sites shortly.
Awesome. Dr. Britton, thank you for being a guest on the Project Purple podcast. It's been an honor to have you on, and thank you for all you're doing in the pancreatic cancer space.
Thank you so much for giving my project the opportunity. It's been wonderful to talk to you, and it's so lovely to hear about everything that you're doing for patients and philanthropy. Very inspiring.
Thank you. Thank you for listening to another episode of the Project Purple podcast. If you liked today's episode, feel free to share this episode. Make sure to follow us wherever you listen to podcasts. That's a wrap of another episode of the Project Purple podcast. Until next time, please be safe, and thanks for listening.